I am delighted to introduce to you as well Dr. Amy Abbott. Dr. Abbott has a distinguished career here at Creighton School of Nursing, not only as a student completing her BSN and her master's degree here, but since she's completed her doctorate at the University of Nebraska Medical Center, she has done some phenomenal work. She's an outstanding critical care nurse who's taken her passion for quality patient care to work in an interprofessional environment. Similar to Dr. Costanzo, Dr. Abbott teaches in interprofessional health and safety courses throughout Creighton University. She's also, because of her expertise in health services, has been able to contribute to some phenomenal publications. I'll give you just an example. She's part of the Creighton Center for Health Services Research and Patient Safety Program and is the lead nursing faculty on this interdisciplinary faculty collaborative that's been funded by the Agency for Healthcare Research and Quality to focus on patient safety and health information technology. She conducts research on care transitions as well as patient and provider perspectives on ways to improve that, and interprofessional use of health information technology and interprofessional patient safety education. She's produced 2 book chapters in the first interprofessional textbook on patient safety. It's called Foundations in Patient Safety for Health Professionals. She's done numerous technical reports and peer-reviewed publications in the field and presented papers in national conference, including the premier health policy conference, Academy Health. She's received competitive funding as part of her interprofessional teamwork and is currently also one of the fellows, along with Dr. Costanzo, from Creighton University that's part of the Health Disparities Research Center at the University of Alabama at Birmingham. Her scholarship addresses essential elements of designing systems for care and education that enhance patient safety, including privacy and security issues in electronic health records, perspectives on the use and adoption of electronic health records, personal data assistant use by providers, care transitions, and health outcomes analysis. She does a wonderful job with this, and I think it's critical to hear her insights on patient engagement in managing their own personal health information. One of the hopes as we look at bundled care and integrated care is that patients will be so well engaged in their healthcare delivery that they'll be able to advocate better for themselves and their loved ones. So part of that is the patient becoming the holder of their electronic records, or whatever way we decide to put records together. So with that, I would like to welcome Dr. Abbott to the podium to talk about the personal electronic health record.
Good morning, and thank you all for coming. I'm excited to talk about a project that I've been working on through the Center for Health Services Research and Patient Safety, and it's engaging self-care through use of personal health records with diabetic patients. The funding source is through the Agency for Healthcare Research and Quality. I was lucky enough to be part of this research interprofessional team, one of which is Dr. Kevin Fuji. I don't know, Dr. Fuji, are you here? If so, wave. He ditched me. No, I'm just kidding. He said he was going to try to come. He's a pharmacist and a faculty member in the Center for Health Services Research and Patient Safety. And other key research team members, Dr. Kimberly Gauld is actually the principal investigator. She is the one who received the funding through AHRQ. And Dr. Anna Mayo, who's a physician over at CUMC's Internal Med Clinic. Also Ted Kasha, who is a data specialist. Other key contributors, Dr. Angela Drinzik is the endocrinologist that helped in the process of getting this grant. Carolyn Manhart, Mark Kraft, Michaela Piccolo, and Heather Jensen are all research assistants who have worked with us. Mark was a pharmacy student, Michaela was a nursing student, and Heather is a social worker. So it was a very good group of people to work with. The objectives of our project were actually to describe how patient-centered health information technology has the potential to impact the patient-provider communication, relationship, and ultimately how will patients engage that they could improve their health outcomes and enhance their care. Also to illustrate the use of an electronic personal health record and managing patient health information by type 2 diabetic patients. And we wanted to describe the lessons learned that could help enhance patient participation in their care. And that's really a big challenge, is because if they don't take ownership and get involved, it's hard to do it for them. I mean, you have to have their buy-in. And that's what we were hoping to get through our study. I do also want to acknowledge the entire internal med clinic at, well, it's Allegiant Health CUMC, and also the Dundee Clinic. Their staff, all the physicians there, and the nurses were phenomenal in helping us facilitate this process. So patient-centered health information technology really are centered in some main types of personal health records, patient portals, and mobile health applications. And so what are these things? But personal health records are electronically driven, patient-controlled, comprehensive records of health. So patients can enter their data, their information, and track it so that they have a comprehensive record that's theirs, that they have taken ownership for, and they've entered the data. Patient portals are a little bit different in that they are still patient-centered. The patient has access, but their health information, their records are able to be pulled into the actual documents, and they also can communicate with physicians. They have email capabilities back and forth. They can message their doctors, etc. In mobile health applications, when they say there's an app for it, they are not kidding you. So any of us out there with smartphones know that we can track how many glasses of water we drink in a day, the calories we eat, the calories we burn. We can scan barcodes of food items and have it bring the information in, keep track of our protein, our carbohydrates, etc. And so there really are application-driven things that have the potential to impact how patients provide care and track care for themselves. Personal health records are defined as patient-controlled electronic tools for them to maintain a comprehensive health history. And each type of personal health records has a few different characteristics I'll talk about. But the exciting part about personal health records is they have the potential to make some big impact on healthcare. We hope that it will, it has been shown to enhance patient knowledge when they can see and realize what they're doing, see it in front of them, look back at it. It makes them more knowledgeable. It also has been shown to improve self-care behaviors. They can see where they're doing, what they're not doing, and how that impacts their outcomes. And also to facilitate shared decision-making between patients and their healthcare providers. Stage 2 meaningful use criteria for electronic health records were just released by the Centers for Medicaid and Medicare Services. And it is the requirement that patients do have to be provided access to their health records. Now, if you can imagine, in light of health literacy, problems with connectivity, etc., just providing access doesn't mean that everybody has access. And so that will be an area that's definitely going to need to be tackled in the future as well. So there are three major types of personal health records identified: provider-tethered, payer-tethered, and standalone. Really, with the provider-tethered, it is that it's tied to a certain provider. Health information can still be pulled in those health records. Similarly, the payer-tethered is who's the paying participants, who's the insured, etc. Standalones are just that. They're by themselves. The patient's the sole responsibility, has the sole responsibility for moving any information in and out of it. Sadly, in 2011, only 11% of consumers in the United States were using personal health records. Most of what we see are the piece of paper in a wallet that's, completely worn out, that has a med list or things like that. And so it's better than nothing. It doesn't say that it has to be electronic, but really keeping track in some systematic format. There is also minimal use of research examining the use of PHRs by patients with diabetes. And as you can imagine, for anybody with chronic health illnesses and things that require day-to-day management, they kind of get lost in the everyday mechanisms. It's like, well, that happened, was that Tuesday, was that, I don't know. And so if they have a record of it, it makes it more accessible. They're less likely to forget when things happen and provide better histories to the providers and to bedside caregivers. So PHR and diabetes, our purpose was to explore how people with type 2 diabetes use a personal health record to manage their diabetes-related care. And so why did we chose, I guess I should tell you, a standalone PHR. And the reason we did it is they're readily accessible. We knew that we could teach and empower the patients to do these, but the payer and provider tethered had to be accessible where we were studying. They also were not well studied. So we thought this would be a great opportunity. We did an extensive review of the literature, and I can't even remember how many. I think there were 50-some standalone records or PHRs, electronic ones identified. We went in and signed up for an account on every single one of them, made a table of what we wanted to know in our study, and tracked them, and figured out which one will give us the best information back. And this meticulous and methodical process was a good practice for a couple of reasons. The Friday before we started our study, we had originally were working with Google Health, developed all our training brochures, all of our manuals, everything we had, and Google Health sent out a message saying that they were closing as of January 1st. So we had to scramble, so we went to our next pick, and so had we not done that process, we could have been in some trouble trying to get our study started. But we figured we may as well do everybody on the same program. And so what we used is Microsoft Health Vault. And I've listed the website there. It is a no-cost commercial product. It's free. You go on, sign up for an account. You can track your information. It's accessible anywhere with internet access. So God forbid you're traveling and have an emergency and need to access your medical records. All you have to do is go online. You can pull it up and you can share it with whomever's there providing care for you. Obviously, it's only as good as what the patient puts in it, but it still is something that's a little more accessible. Patients all received a standardized training program. We developed a brochure, spiral bound, pictures, arrows, numbers. They could follow the directions very simply. But we also individually taught each person at their enrollment. So they came in, said they would like to be in the study. We consented them. They met with their physicians, and then we met with them afterwards. Some patients took 15 minutes to train. Some people took an hour and 15 minutes to train. But we trained them all individually, and so we knew that they had set up the account. We had them share the account with us so we could go in and peek and see what they're doing or not doing. And obviously, they were given access to this PHR free of charge as well. So this portion of the study is actually a qualitative exploratory design. Participants were purposefully selected, and the homogeneous sampling group we used were all patients who were in the PHR arm or intervention in this randomized controlled trial that we did, and it is part of a larger mixed methods study. So 70 patients with type 2 diabetes were in the control group, and 70 were in the intervention group. So we're looking at the 70 who used or didn't use the PHR. They were enrolled from 2 internal medicine clinics in a Midwest metropolitan city, which I already told you about. Real secretive, huh? Anyway, the data collection methods, if any of you are unfamiliar with qualitative research, I was a quantitatively trained researcher, and all of my practice with this group has been in mixed methods. So we do qualitative and quantitative. And although fascinating, it is very, very labor intensive. And so after you collect your data, we used a semi-structured interview protocol to ask patients about how and why they used the PHR. All of the interviews were audio taped, transcribed, and then we reviewed them and developed what we call in vivo codes, where you actually use the patient's terminology to describe the item you're trying to identify or the category. We did that independently and then came back together to see where we matched, where we didn't match, if we liked others' terminology better, and if it really was reflective of what we collected. This study is ongoing. As of currently, when we analyzed the data, we had 59 of the 70 who had completed the interviews. I think we're up to 66 now. We have the last 4 that were begging to come back and see their providers. 36 were females, 23 males, an average of 57 years of age, so that in trying to engage them in computers. And really, the only criteria for admission, they had to be a type 2 diabetic, they had to be English speaking, they were self-proclaimed having a computer or having computer knowledge, and a hemoglobin A1C greater than 6. And so we included everybody, and then we're going to stratify based on A1Cs as we get the rest of the data in. Average years since diagnosis was 12. So these people had been diagnosed for many years, which will shed some light on, I think, some of the findings we have. So we went in, we asked patients during the interviews, and we checked to see what they actually tracked in the PHR. And so for any of you considering use in this PHR, all of these things are able to be tracked. They can track all lab values. They select the lab. You can do glucose, blood pressure, weight. All of them tracked their medications, that we had them enter a medication so we knew they knew how to do it. Some of them got fancy. They put in their family history. They put in their healthcare provider's contact information, immunization, things that we had not instructed them, like we had the minimum things we wanted them to do. So we identified 7 themes through this research, and they're listed here, and I'll go through each one of them separately. So the first theme is difficult to use. So participants share what difficulties and struggles they had. And some of these problems, unfortunately, began with logging in and continued throughout the data entry process. One participant said, "I'm trying to sign in right now and I can't even remember my ID. Isn't that terrible?" Other participants said that really it could be simplified. She just said, "It takes too much time and is way too frustrating." Also, situational access became a problem. Some patients had reported lack of continued internet access, either for a financial problem where they could no longer afford it. Others reported that they had their computer broke, they couldn't access it at work. Some lived in rural communities, and they had slow or no internet access and were relying on going to a library or some other place, a relative's house. And obviously, if you have to rely on someone else and some other access, it makes it very difficult. I did tell you that we asked people if they were knowledgeable in computers and had computer access. So it was a little funny that one of our patients said, "I'm not really a computer person, so for me to get on, it took a while." So that did slow down the process for many of them. Life got in the way. We heard this over and over. And participants really shared with us how a variety of issues led to their sporadic use. Some actually were displaced because of the Missouri River flooding and just couldn't find the time or the energy to do it. They had other responsibilities. Having to deal with families' health care problems. One lady reported that they had a death in their family and nothing else really seemed to be important. Some were personally ill, in and out of the hospital, a variety of illnesses. Some had injuries. Many had family obligations, driving kids to and from places. The things we do on a daily basis, but adding something new into the mix just wasn't possible. One patient just said, "Life got crazy." Out of sight, out of mind. I think we all fall into this in a variety of reasons. Certainly that assignment won't be due if I tuck it in a folder and hide it in a book bag, even though I carry my book bag to and from work every day. I have it if I want it, but I don't really look at it, so all of a sudden it's time crunch. And patients said that sometimes their daily life, that life craziness, led them to forgetting to use the PHR at all. I never really got in the habit of using it. It was out of sight, out of mind. It wasn't part of their daily routine. Some said I just felt lazy. It actually required effort on my part. Well, exactly. And so some of the best things for us require some effort on our part. And so you have to get the buy-in of the patients and the belief that they are able to make a difference and able to do something that's going to positively impact their health care. Double tracking. I get it. We all do a lot of double tracking in our lives, and we do things on the computer, but we want a paper copy, and then we stick the paper copy and we lose it, and when we get home, we don't have access to the copy we thought we did on the computer. And that's kind of what the patients told us. It did not replace their currently used tracking tools. So they were double tracking. Patients reported that they had an Excel file. Some had written records. Some just used their memory. Some had printouts. And many used their glucometer. So the glucometers now can be downloaded and all of their information's ready, available. You can hit a button that shows you what your last few are. And so to do something else seemed redundant to them. Being able to average and get my blood sugars in an Excel file is what I'm used to. I did put a few things down at the beginning, but I usually just kept track on paper. It was easier for me to write it on the paper by where I test my blood sugars. And this participant went on to explain that going in the bedroom and getting on the computer and getting the station set up after someone else had used it, getting it where it was convenient for them, was a pain. The patients who did engage and who really had positive things to say about it were thrilled that they had a complete and accessible record. They found it useful to have everything in one spot. They used it as a general overall record of their health, and a patient said, just knowing that there is a record too that I can go to all the time, and she went on to say that it was reassuring. She said, if something happens and I need medical records, now they can get it. Where a lot of people in different facilities, and some in the same facility, have different records, different computer systems that don't communicate. So this was reassuring to them. Most of those people also reported an increased awareness. Those who engaged said they became aware of changes in their diabetes-related care as a result of this. And the reason for that, and the feature they liked, was a visual chart. By hitting one button, it would graph their blood sugars. So they could see ups and downs. They could go back on those days and see if there were medication changes. They could look to see if, it was after a holiday weekend and we had relatives in town, depending on how they documented it. So it was a graphic representation which shows them more than the spreadsheet or the handwritten paper with a whole bunch of numbers on it. One participant described viewing her progress over time. I think it's more of a reminder when I go put those numbers. It isn't like you take them and forget what they are. I go back and look at them and, wait a minute, I was kind of messing up there. I should do better. So suggestions for PHR improvement, they all wanted us to hear what they thought could be better. In one of the sections in the lab values, you have to know what the label is, a percentage, a milligram per deciliter, etc. And they would have liked that to have been a locked-in field that they didn't have to remember. She said, I was trying to enter labs and it wouldn't accept the values unless I knew those letters afterwards. Also allowing patients to link their medications and blood sugars on the same screen, they would have liked to have seen. They wanted reminder contacts. They wanted someone to call them and remind them to use their PHR, which I thought was cute. Overall, many said that it was easy to understand, quick and easy to use, and usually computer programs aren't like that. So what did we learn? There is great potential for standalone PHRs to help connect people across various healthcare settings and providers. But it does require provider engagement, even though it is a patient-centered technology. These physicians were very well aware, as we stood there almost 40 hours a week enrolling patients doing these things, that they were involved in this study. They were explained, they were presented it. And we did not have one patient report that any provider asked them to see their personal health record, which was very disheartening. We got excited because somebody actually charted, one of the providers actually charted patient in the PHR study, but never asked the patient about it. And so if they don't see that anyone else thinks it's important, it's hard for them to, they have to want to do it for themselves. And I think everybody likes reassurance that what they're doing is good and their providers would provide feedback. And I think nurses are in a key role to do this. We can encourage the use of PHRs and patient portals by empowering patients to take charge of their own health. They're in control, and to use information that they have. Wouldn't it be great if you came in and your patient provided you with this information? They can print it out. They could give you the web access. You could go in and look, and that information could be moved right into the admission database. We'd have all this information readily available. And so we need to help them see where their self-care behaviors or lack thereof cause changes in their outcomes. Help them see that, oh, you know what, you haven't done your, all of these things. You haven't had a foot exam, you haven't been back in the last year, you don't track your diet and exercise. We can't see that there's any record of your blood sugars, but what we do see is this. And if you could say, you know what, every time you leave the hospital, your blood sugars are consistently high, and you go home and return to your same, behaviors, we're never able to get those levels lowered. So if we could help tie in some of these outcomes as related to their lack of care, they may help see things differently for them. Findings do suggest that patients do not perceive the PHR as a better way to track information. Rather, it's an alternative way to their currently used tracking tools. We all know how busy we get, and so to double work is very frustrating, which led me to believe that maybe because these people have been diabetics for 12 years, we're targeting the wrong group of people. Maybe we need to look at newly diagnosed type 2 diabetics and see if we can engage them earlier in this type of a tracking mechanism where they buy in early, they can see the benefits, and they start out doing it, where they haven't established their routine about how they're going to track and what they're going to do. While there are no recognized benefits to PHR use in enhancing patients' awareness of their diabetes-related care, or while there are recognized, there are also many barriers that inhibit effective PHR use. We gave them a very thorough training program. They had access to us by phone and by email to call with questions, and many did. And so we were able to guide those back as needed who took the initiative. This viewpoint does also illustrate the role that current standalone PHRs may play in patient record-keeping behaviors. So here are the list of references. If you have any questions, even though I didn't say I welcome on a slide, I do welcome any questions or comments you have. I do think that if it was provider tethered, where there was more communication, and also in those where you can message the physician and communicate, it does seem a little more engaging. So we don't really know what the long-term outcome will be of standalones, except they do offer the uniqueness that they travel with you, they are free, and the communication piece is definitely missing. So, good comment and questions. Anyone else? Yes. How would they express that they had a PHR, or how would they get the information to us? Yeah, they would, exactly. We would hope that they had given access to another family member or a healthcare provider so they could get the password and print the information off and provide that to us, or if they knew the password, we could go online right there at the point of care and open it up and pull in that information. Yes. And it was interesting because we asked several of the people in the clinic, do you think, you know, Dr. So-and-so or Dr. So-and-so, do you care if we gave patients your email? Because then they could link it. It wouldn't, you know, they didn't want the patients to have their email access. So it almost needs to be a method by which it can be communicated, or that they give their password to the provider and the provider signs up with permission. There's got to be a mechanism that helps facilitate that process so that it's less labor intensive and the physicians and providers can get the information they need without feeling like they're giving away private information. Great, thank you all.
Thank you, Dr. Abbott, and thank you for the creative work your team is doing. You can see there are a lot of different opportunities for us to explore all the different ways we interact and can coordinate care. So, very exciting. One of the joys of working